Dysmenorrhea refers to the painful menstrual cramps originating from the uterus occurring just before or during the menstruation. Primary dysmenorrhea, painful menstruation without any underlying pelvic pathology, typically starting within the 6 to 12 months after the menarche. Secondary dysmenorrhea, painful menstruation due to the underlying pelvic pathology, often beginning later in the reproductive life. Primary dysmenorrhea, excessive production of the prostaglandin, mainly PGF2 alpha in the intermittent, leading to the uterine hypercontractility, ischemia and pain. Secondary dysmenorrhea, endometriosis, adenomyosis, pelvic inflammatory disease, uterine fibroids, cervical stenosis, and the intrauterine devices. Pathophysiology. Prostaglandin causes the increased myometrial contraction, vasoconstriction, and the ischemia of the uterine muscle, leading to the cramping pain in the primary dysmenorrhea. In the secondary dysmenorrhea, pain arises from the underlying pelvic pathology with additional inflammatory or the structural mechanism. Primary dysmenorrhea, lower abdominal cramping pain starting 1 to 2 days before or at the onset of the menstruation lasting 12 to 72 hours. Associated symptoms like nausea, vomiting, diarrhea, headache, and the fatigue. Secondary dysmenorrhea pain starts earlier in the menstrual cycle and lasts longer than the primary dysmenorrhea. May have the dyspareunia, painful intercourse, menorrhagia, heavy menstrual bleeding, and intramenstrual bleeding, and the fertility depending on the underlying cause. Primary dysmenorrhea clinical diagnosis based on the history and the absence of the pelvic pathology on the examination. Secondary dysmenorrhea pelvic examination reveals abnormalities, tender nodules in the endometriosis, enlarged tender and the uterus in the adenomyosis. Imaging, pelvic ultrasound MRI if needed. Laparoscopy for the definite diagnosis of endometriosis if suspected. Differential diagnosis like the premenstrual syndrome, pelvic inflammatory disease, ectopic pregnancy, and ovarian cyst. Treatment like the primary dysmenorrhea, first line NSAID, ibuprofen, and the naproxen to inhibit the prostaglandin synthesis. Hormonal therapy like a combined oral contraceptive to suppress the ovulation and reduce endometrial proliferation. Heat application to lower the abdomen. Regular exercise, dietary modification, low-fat vegetarian diet. Secondary dysmenorrhea, treat the underlying cause. Laparoscopic excision for the endometriosis. Antibiotics for the PID, surgery for the fibroids. Hormonal therapy, GnRH channelers, progestins in the endometriosis and adenomyosis. Dysmenorrhea is painful menstruation caused by the uterine contraction and the ischemia. Primary dysmenorrhea is due to the excessive prostaglandin without the pelvic pathology. Secondary dysmenorrhea is caused by the underlying conditions like endometriosis or the fibroids. Primary dysmenorrhea typically begins with the 1 to 2 years after menarche. Secondary dysmenorrhea presents later in the reproductive life with additional symptoms like dyspareunia and menorrhagia. Prostaglandin, especially PGF2 alpha, play a key role in the primary dysmenorrhea. NSAID or the first-line treatment for the primary dysmenorrhea by reducing the prostaglandin synthesis. Combined oral contraceptives help by suppressing the ovulation and reducing the endometrial proliferation. Pelvic ultrasound is the initial investigation for the secondary dysmenorrhea. Laparoscopy is the gold standard for diagnosis by endometriosis. This is the most common cause of the secondary dysmenorrhea. Heat application and exercise can provide the symptomatic relief in the primary dysmenorrhea. Persistent or the progressive dysmenorrhea warrants the investigation for the secondary cause. Secondary dysmenorrhea associated with the infertility is often due to the endometriosis. GnRH channelers are used for the refractory cases of the endometriosis and adenomyosis. Differentiation from the PMS is essential as PMS presents with the mood changes and other symptomatic symptoms.